Good afternoon, everyone, and welcome to the Salford Human Movement Rehabilitation Research Group online launch event. As you might have noticed if you're eagle-eyed in the initial video, my name is Dr. John Head. I'm a clinical prosthetist and an academic here at Salford, and I'll be co-chairing this event with my colleague Jasmine Sarwar. Just a quick bit of housekeeping before we begin. Could I ask that all attendees submit any questions during and after each presentation into the Q&A panel on the right-hand side of your screens. If you've got a question you'd like to ask but someone else beats you to it, don't worry, but please feel free to like that question by clicking the featured tab and then clicking the thumbs up icon on the relevant question. So without further ado, I'm very pleased to welcome our first keynote speaker of the week, who is Professor Cathy Holloway. Cathy is Professor of Interaction Design and Innovation at the University College London and the Academic Director of UCL's Global Disability Innovation Hub. Cathy is also the Research and Innovation Lead of the Department for International Development funded Assistive Technology 2030 programme, which aims to test what works to improve access to life-changing assistive technology for all. Cathy's team is working with our Salford group in the Fit for Purpose Prosthetics project, and I'm delighted to welcome her to begin our launch event with her presentation entitled Prosthetics 2030.
Hi everybody. So it's a pleasure to join you on your launch. I'm working with Lawrence Kenny and others on the Fit for Purpose grant, and we've worked on other projects together over the years, and I've always greatly appreciated travelling up to Salford and working with you all. So I'm honoured genuinely to be here with you today and to kick things off. I thought I'd focus, initially I said I'd do all global human movement health, and then I realised it's quite difficult to fit that into 20 minutes. So I've tried to hone in on prosthetics and just begin to think about what the future might be, so when we get to 2030 where we might be. So just in case you don't know, the Global Disability Innovation Hub, and the reason I mention this here is because we obviously work with you and we want to work more with you, but we work in research, teaching, innovation, programmes and advocacy, and we now work in 33 countries and have a research portfolio of about £40 million. But it's across assistive technology, inclusive design, culture and participation, and it's the merge of those that makes us a little bit unique. So the kind of flavour of the type of work that we do can be slightly different to the kind of work that happens in Salford, where obviously you've a very strong technical focus on biomechanics and human movement. We take a bit of a wider approach. So I mentioned that just to set the scene for what I'm going to talk about, which is not going to be highly detailed biomechanics, which I did once do, but I feel sort of, I don't know, it's nearly 10 years ago now, I think, so it's in my past. So the culture and participation comes through a lot in the types of studies that we do. So everybody knows this, that assistive devices are designed to bridge functional gaps between what the capabilities of a person and what they might wish to do. But we also know that social considerations play a huge role. So we're going to hear from people after me about some of the projects, which will take deeper dives into some of this work. But some of the work we've been doing is looking very much at identity and embodiment and self-expression. And there's some great work happening in the prosthetic space where human-computer interaction meets prosthetics, and you get these tensions between designers that want to just make your own prosthetic, and then clinicians that are like, hang on, don't do that. That's going to be a really bad idea. Do no harm first. And so my personal research works at that interface. But beyond that interface, we're also working and trying to understand how do we best influence the people that could make the biggest change. So we know that even by making a better limb or by even providing a new service within a country, there's still a chance that governments won't fund that, or that we won't be able to scale that provision. So we're working across that sort of spectrum. And one of the things that we've done recently is partnered with the Clinton Health Access Initiative to develop what's called a product narrative on prosthetics and prostheses. So some of you will already know this, so excuse me if you've heard this before, but I think it helps set the scene quite well. And the thing is, with a product narrative, the reason I mention it today is not so much to teach you or to tell you about the things that are in it, but to also explain why I think product narratives are important. So if you work in assistive technology, if you work in prosthetics, if you work in eyeglasses, if you work in hearing aids, you know that there are supply and demand problems. You know that there's problems with getting devices that are affordable to people, that offer high enough quality, and you know that there's service provision issues, and you know there's a shortage of clinicians in the space. You know all of that. The problem is that when you go and speak to governments, so recently, speaking to the Kenyan government, for example, the first time I talked to them about assistive technology, they just have no idea what you're talking about, like, literally no idea. And then when you begin to mention it, they think it's a very small niche problem that they don't, it's not really for them. And so part of the product narrative is to actually be able to tell the story to people that will be able to fund kind of at scale. And so product narratives were part of the 80-20-30 program, so they were funded by 80-20-30, but they are for the at scale partnership. And just to be clear, the 80-20-30 is a project like any other. It's funded to do some work and it will end, but at scale is run by people like the WHO and UNICEF, and they are hopefully going to invest many more millions into the assistive technology market. So, you know, I'm sure that there are 65 million people living globally with amputations who need prosthetic limbs or would benefit from prosthetic limbs. And roughly speaking, even though, let's be honest, the data is pretty rubbish, about 5 to 15% in LMICs in low and middle income countries have access to that assistive technology. So we know there's about 1.5 million people a year adding to that. So it's going to roughly double by 2050. And you can see the graph on the right, product narrative. I can send you, if you're interested, gives into the more details of this. But majority of people are lower limb across the world, and fewer are upper limb amputees. And obviously there is a supply and demand mismatch there. So if you look at the actual market, so rather than looking at the problem from a clinical point of view or looking at the problem from a mathematical and engineering point of view, if you just look at the market, there's a problem with investment. So the first problem is that it's globally dominated by a few companies, and they're mainly focused in high income countries. They are not incentivized at the moment, sufficiently incentivized, I should say, to develop product and service opportunities in lower middle income countries, and that's a problem. There's also a current lack of governmental input, and so not-for-profits are filling that gap, and that's both good and bad. And you're going to hear about some really great not-for-profits filling the gap in some of the talks that are coming after me in this session. But there are also not-for-profits that are maybe not so good that are filling the gap. But also when you're giving away a device for free through a charity model or not-for-profit model, you run the risk of creating no value within the system. Like the government won't pay for something if they know somebody else will provide it for free. So we end up with this tension that even though we can have really great work happening, we're still dependent on sort of donations to keep that world going, or that service provision going. We also, and Lawrence and I have been working on this for a number of years, have very poor amputee data. So this leads to a lack of advocacy, or if we had better amputee data, we could improve the advocacy. So I don't just mean that at an individual level. So if I'm a prosthetic user and I have a thermal comfort issue, if I had sensor data that kind of helped me explain the problem to my clinician, to my prosthetist, then I have a more informed conversation. So that's at a very individual level. But at this level, we're looking at actually how do we show that prosthetic devices enable people to walk further, stay healthier, and then link those to health indices over term? Or how do we help them show that one prosthetic device is better than another so we can drive investment? And how do we show there's basically an improved quality of care using this model versus that model? The second area I wanted to talk about is pathways to provision. So we have poor referral pathways from amputation to rehabilitation. So we get a drop off. So we know, anybody who's been to a low middle income country and worked there knows that the distances are huge and it's costly to travel, but it's also costly because you have to take time off work, or somebody else has to take time off work to transport. And so at each point there's the ability for someone just not to re-engage, and that is a problem. The second problem is, or the second opportunity, I suppose, is that we realised that we could decentralise some of this. So we could maybe have it not that the user has to come to the clinic or a mobile clinic has to come back to the user. We could potentially decentralise some of this, but nobody knows yet if it's cost effective, or even actually if anybody agrees that the quality of the product or service will be adequate if we decentralise. And then we also know that innovative socket fabrication. So I think it's the last talk in this session today, we'll talk about a new socket. There's lots of new socket fabrication happening. We work with Amparo, but we're also developing our own sockets with sensors. Loads of stuff happening, but the adoption at maturity is very limited. So we still go back to the standard liner, and that standard liner is way too expensive in an LMIC setting, and so we end up with problems. So procurement and procedure. Affordability is a barrier. That's a barrier for everybody in fairness, but in low and middle income countries, it's particularly a problem. And so it can lead to, which we see in wheelchairs and we see in eyeglasses and hearing aids in particular. You know, in the hearing aids, I've heard, I won't name the manufacturer, but they're offering the gift of sound. So they've developed a hearing aid where you can't hear, but you'll be able to hear noise. But they know that, so they don't qualify that you'll be able to hear, but you'll have the gift of sound, and therefore that gift of sound is like bought by government. Says, okay, now I've ticked that box. That's a hearing aid's done, but it's not the quality that we would expect. And actually, it's probably, in my opinion, there's an ethics board that I think they're on the wrong side of. So we need to make sure that that not only is a product's affordable, but they're of the high enough quality, and that components can be repaired. So oftentimes when components fail, that's when devices stop being used. We don't have responsive supply chains, but we could have. There is an opportunity, and they're irrespective of how you deliver. We've got a huge human resource capacity as a limitation, and we know that there's novel ways to expand this, but we also know there's resistance within the community to have that expanded, and so that there is a tension there. So this leads to the following market challenges. On the demand side, when you actually talk to people, especially with upper limb prosthetics, that people aren't aware that they exist, or if they are aware they exist, they're aware of a certain type of device, maybe just a limb that looks like a limb rather than a limb that's functional. There's low political will. It's very difficult. I mean, even so now in times of COVID, in some ways it's harder, in some ways it's easier, but you're trying to convince governments, which are limited budget, to invest in an area that they don't understand, that every time you speak to different people, they ask for different things. So when they hear about assistive technology, they're not sure where to invest or how to invest, and it's complicated for them. We have a lack of funding for products and services, so even the stuff that's working well, we are not able to scale. The out-of-pocket expenditure for people is high. A lack of prosthetists and access points, and decentralisation is slow. On the supply side, there's a lack of product options in LMICs. The current modular options are too expensive, and there's a lack of local supply chains, and that's very important for when products fail. And as we found in the Fit for Purpose project, even if we've got, sometimes you have the ridiculous situation where you've got personnel, but the budget hasn't been given for operational, like for components. So you can have, so different lines of the budget can be covered in different countries. So in Uganda, yes, we've got this resource, but we don't give them a material resource to actually do their job. And then in other countries, like in Kenya, for example, we see there's a lack of the resource, but we've got components. So, you know, you end up, no matter where you go, with this mismatch. So there are things called enablers of a market, and they can sort of help things get started. And for prosthetics, there's three areas that if we began to, it's like problems which are opportunities. So the first is data. So there's no defined outcome measures that people are happy with in terms of the economic benefit of prosthetics. So when you talk in the healthcare world, people are interested in things like malaria nets, or here's the new HIV drug. This will offer how many more months of living, or this will offer how many fewer deaths. So we can save this number of lives, or we add this many months to people. And of course, for assistive technology, ultimately, we probably do add life to people, because people want to live, and they are healthier by having a prosthetic limb, but we don't quantify it in any way that we can have these conversations. Secondly, the quality. There's a lack of market transparency on the quality of different solutions and components. So sometimes the wrong thing gets bought, or poorer quality gets bought because it's cheaper rather than the quality that we would expect. And finally, there's a lack of gold standards of research guidance for different components and how. So we've got ISO testing, for example, but then beyond that, actually, how do we test in the field? There's some people are using the ISO testing and then moving beyond to the ISPO guidelines. Some people are not, and you get trials that are. Every trial seems to have a slightly different approach, and often some trials are not in the public domain because they're held by those main manufacturers who are obviously keeping their competitive advantage secret. So this leads to a few strategic objectives. I'm just going to very quickly go through these because there's a couple of other things I want to say, and I don't want to overrun too much. But basically, we need more data. We need to support the governments to define their investment policies. Then we need to accelerate the market validation, adoptive innovation, or innovative technologies. So we need to give confidence to people that these technologies work, technologies that you guys are creating, in fairness. Then we need to make those affordable. So how do we scale it so that it is affordable and potentially take advantage of different ways of distributing and financing models so that the components and the prosthetic devices become affordable and available. So I believe that none of that will be possible without partnerships. We are working across the world at the moment in different places trying to build these partnerships, and some of those partnerships have come from Salford and been opened up to us, and we're very grateful that GDI Hub has an opportunity to work with Salford and their partners on these problems. But I think that we are going to have to go across the traditional divides, and so I would challenge especially the younger people in the room to think outside of their box. And I know, for example, Robert, who's coming up later, is already doing that. So in terms of how does GDI Hub respond to that global challenge in prosthetics, well, more generally, we're trying to support innovation. And we all know there's a valley of death. Some of my products have died in the valley of death as I was starting out in life in this world. And so we've created two programs. One is called Innovate Now, funded by UKAID, so the 80-20-30 program, and one is the 80 Impact Fund. And I mention this because I would love to see you guys apply and get funded through these things. So one is an accelerator program in Kenya, in Nairobi. You need to have an African base or want to move to Africa. And it's linked to, that should say Live Lab Network. It's quite an interesting typo there. And local and global mentorship, whereas the 80 Impact Fund takes later stage ventures. So you must already have a market fit for your model, a business model that works, ideally some type of investment into your component, and then we will help you scale in Africa. We've got £4 million in the 80 Impact Fund, and we're just backing our first two ventures to operate in Kenya and South Africa. The other thing that we're trying to do is build consensus. So we're going to work with the International Society for Prosthetics and Orthotics. So if any of you were at ISPO, the last big congress, you'll know that I gave a talk which managed to upset some people, which was quite interesting. I didn't appreciate how I could upset so many people in one day. And Claude said to me afterwards, yeah, it's quite interesting, Cathy, you've upset a lot of people. And I said, yeah, no, I really have. I didn't mean to. I just thought, we should talk about this digital transformation. And as part of that conversation from Kobe, we are now going to partner with ISPO on trying to build global consensus, and members of your team are part of that academic working group that will do the literature review, and ISPO will do the consensus building, and we're hoping to get to a point where there is some consensus on how we move forward in digital. And so just about to wrap up now, really, but you can't really do anything at the moment without mentioning COVID. So some of the opportunities I think about COVID are that it is an opportunity to showcase that assistive technology services are broken, so they're really broken at the moment, but also the opportunity for digital to come in and help overcome some of those gaps. So we've published a few papers recently trying to expose and give a commentary on some of the social elements of assistive technology and how, if assistive technology systems were better designed, they would be more robust in terms of COVID, and actually building those more robust systems are important. We've also partnered with COVID Action, which is a different UKAID funded project, to develop a new portal called innovationaction.org. Salford are welcome to be partners. It's just an open partnership at the moment. It's a work in progress. But at the moment, we have a call out across Africa for local production, local solutions. So we have found people that have pivoted into personal protective equipment and have scaled quite rapidly. Some very exciting innovations actually in different countries. And we're mapping those, we're helping them, we're investing in them, we're giving them expertise, access to expertise at UCL and across our African partners. But we're also hoping to we're also mapping the Kenyan AT ecosystem, and then we sort of have a series of these mapping activities. And the idea is, can we find interesting places where we can transfer knowledge between projects and programs? So we've got these PPE productors, could we pivot them long term to work in low cost assistive technology, for example? And that's something that we have been doing. So one of the options of this local production has been trialled with Motivation, who you might know, Motivation Wheelchairs, through their Innovate project. And GDI Hub just helped to do the research on this. The IP, the product is all owned by Motivation. But one of the things we found is that by implementing local production and local designs and the ability for the local clinical team to make adjustments to the wheelchair, that what we found was that people actually had way more pride and empowerment, both of the clinical team and of the wheelchair user the actual product. So the wheelchair user was saying, yeah, there's some functional problems, but we don't care because we love it. And they really want to help then co-design the final product. So I believe that if we bring together this idea of local production and local solution, along with some of the work that we're doing in sensor technology, as well as across new material choices, I think that there's a chance that we can get to assistive technologies and prosthetic devices that tackle some of the problems that still exist, like thermal comfort, but that actually are scalable. So I will end there with a thank you to you all. I realise my last thank you slide is obviously hidden, so apologies, but they just said thank you for listening and any questions.
Thanks very much, Cathy. That was a very interesting presentation. So we're going to move over to John now, who's going to ask you some questions.
Oh, hi. Thanks, Jasmine. Yes, and thank you very much, Cathy. I need glasses now. I was looking at some of the slides there with some degree of interest, and I got a question or two prepared, but then my interest was swayed by what you said that we might have upset the ISPO delegates. I was really interested in that. Maybe tell me after the event's finished.
Yeah, no, it was quite interesting. It was a bit of a baptism of fire for me, but it was okay. It's always basically there was I think a bit of a misunderstanding about what AT 2030 was. So AT 2030 is a project, but UK Aid, or DFID, launched AT 2030 as well as At Scale, which is a global partnership, all at the same time. So they just did that as part of the Global Disability Summit. And I think people were confused. And we presented some work that we'd done some testing with Empower, which is they have a thermoplastic as a socket. And obviously there's contention within the government, within the ISPO community, as to whether or not that's a good idea, right? So, but people perceived it as GDI Hub had decided to invest in Empower, rather than Empower were part of a grant consortium that put a project proposal together, and it was one of the technologies like motivations that we were going to test to see what works. Yeah. So they got very upset that a non-prosthetist, me, would think that I would have the knowledge to invest in a new technology with no clinical expertise, but nobody actually said that in the Q&A. So everybody said like, yeah, you know, nice normal things, and it was only after the dinner when I got back to the hotel, various people, having had a few drinks, wouldn't let me get to my hotel room while they accosted me over various things which were more difficult to understand because they'd had a few drinks and I wasn't quite sure what I'd done to upset them. But yes, it was good in the end. It helped get to a point of understanding. But
well, no, that's absolutely fine. I mean, well, here's one prosthetist you haven't offended. I can assure you of that. And although I have to say, I am partial to a drink at conferences, so I can't bow out of that one. I've got another question though. I think we talked, didn't we? And you mentioned about some of the issues with delivery. And I think one of the things even here I've noticed when I've worked in clinic. And having managers at those centres, sometimes there's a misconception that people have limbs, they're given limbs and they just disappear and they take the limbs away, never to be seen again. And that clearly is not the case. There's a long-term aspect to care. What do you think the challenges are then in maintaining levels of provision beyond that initial point of contact?
Well, there's lots of problems. So I think the same problems exist in high-income countries as low and middle-income countries, except for I think that the environment can be a lot harsher. So we often develop, we might develop materials, for example, that don't work as well in hotter climates or in dustier climates, or so I think there's the kind of the actual environment can be a lot harder on a limb. But I also think that people can migrate a lot. So that can be a challenge, especially in humanitarian crises. We have problems where we lose track of people, so they're moving across borders and across countries. But mainly, I think the problem is, even when I've been working in LMICs, well, it depends which country you're in, but a lot of times it's the stigma thing. You know, GDI Hub came about after the Paralympics in London, and I think we all agreed that London 2012 was kind of a highlight of maybe disability in the UK, and we've had lots of lowlights, so it's nice to have a highlight. Whereas that sort of revolution of thinking about a prosthetic limb hasn't occurred everywhere. So you get people who, even if you give them a limb, they may not use it, and then they'll take it off. But also, if they do start to use it and a component breaks, you might have, how do they contact the clinic? I mean, there might not be power to phone them, so they might not have internet. you've kind of those added levels, I think, of challenge. And obviously, I think the other thing is that people think about LMICs as like almost insanely like one block, you know, and obviously if I'm in Nairobi, my internet is often better than it is in London, you know, so it's genuinely. Whereas the minute you go outside or some rural areas, obviously, you know, there's a drop off. So I think there's also the case that we have to think about, in the same way we should think about assistive technologies not as one lot, or even in prosthetics not as one lot. You know, there's, from a market point of view, they're just different sectors. Like they can be approached in different ways. Like an orthotic, possibly less dangerous to get it wrong, if you like, than a full lower limb. So we can kind of begin to maybe think about how we can use digital platforms and also local capacity to help. But there's lots of challenges, and some of the people coming after me have more hands-on knowledge of the actual clinical problems. So.
Absolutely. Well, look, Cathy, we're pretty much just about out of time, but look, thank you again. Really interesting presentation that went really quickly, and it's obviously it's a really sort of challenging area, but I'm glad to see that there's a lot of work being done to get that provision out to where we can see it's needed. So thank you once again for your presentation.
And congratulations once again on the new centre. It's great.
And have you got used to being called just finally Professor yet? Are you used to that?
No, I'm not very good at saying it. Sometimes the actual title, you know.
Yeah, well, it's very well earned. It's very well earned, and thank you again for your presentation.